for the National Eating Disorders Association's Parents, Family, and Friends webinar series. Today we will be presenting Obtaining Treatment Authorization in the Complex World of Insurance. My name is Diana Calagrides. I am the Program Coordinator for NEDA and will be helping to moderate the discussion. We're very pleased to have with us today our wonderful presenter, Dawn. I'd like to take a moment to briefly introduce her. Dawn Lee-Akers is the Family and Friends Liaison and Insurance Specialist for Diabulimia Helpline, a nonprofit organization dedicated to support, education, and advocacy for people struggling with diabetes and eating disorders. In her position there, she assists clients and their loved ones in obtaining the insurance coverage so desperately needed. She works closely with many treatment center business offices and has worked with Cantor & Cantor law firm, renowned for their advocacy, helping those with battle insurance. Through this work, she has been able to develop research materials to help clients maximize the benefits they experience under their respective and varied insurance policies. She has also developed strategies for working with Medicaid and uninsured clients. Welcome, Dawn, and thank you for sharing your time with us.
Thank you. Hello, everybody. I'm very glad to be here.
I would like to let everyone know that this webinar will be recorded and archived and available to view through our website at www.nationaleatingdisorders.org under the Media Center tab. Thanks a lot, Dawn. So we're going to go ahead and move on with our presentation. So I'd just like to briefly discuss the control panel that all of our attendees should be viewing on their screen. All attendees are on mute to control for background noise, but you are encouraged to participate by typing in your questions or comments, and you can also use this feature to let us know if you're having any technological difficulties or trouble with your audio. All right, so Dawn, I'm going to go ahead and hand it over to you.
Okay. So let's see, do I have it now? Yep, okay. Okay, so just really quick what we're going to cover today, how to learn the entire insurance industry in an hour and a half. We'll do the best we can. So the first is learn the language. You have to understand the language that's in your policy and the language that your insurance company is using and that the medical team is using in order to be able to leverage your benefits. Know your rights. We've had a lot of wonderful legislation passed in the last 5 years, so knowing what that is important. Knowing the steps to optimize your chance of getting a yes on the first try. Every policy has an appeals process, but when you or your loved one is in need of treatment right away, you don't want to have to wait to go through that appeals process. You don't want to have to try to pay out of pocket while you're doing it. So getting a yes on the first try is probably our primary focus of the session today. Also knowing how to read your policy, a lot of samples that we'll go through. Knowing where to find and how to interpret your mental health parity laws, knowing some tips and tricks on how to maximize your benefits, have some understanding of the appeals process, mostly because how you go about requesting your authorization will help put you in a better position if you do have to go through that appeal. And then I have a slide on some options for people who are uninsured or underinsured. There we go. So just the basics. So key terms relating to treatment. Medical necessity. Medical necessity is that the treatment you are requesting is necessary for the condition that you have been diagnosed with. It's not specific to what we would think of as a surgical or medical diagnosis. It applies to brain disorders. The laws that we have in place now say that an insurance company cannot discriminate on behavioral disorders or brain disorders versus other medical and surgical diagnoses. So for example, A company might try to deny care to someone with anorexia because their labs are fine. Labs aren't even part of the diagnostic criteria for anorexia, so if that's what you have been diagnosed with, then you have a medical necessity to have treatment for that illness. Let's see, accepted standards of care. These are the appropriate treatment protocols that the industry uses for eating disorders. Especially note that appropriate does not mean average. So the American Psychological Association has defined appropriate levels of care for each of the various eating disorders. That's what your insurance company is required to authorize and provide for you. Average is not a good enough standard. Evidence-based treatment. This is a term insurance companies love to use. It relates a lot to the treatment modality, which I'll talk about in a second, the treatment plan. Your insurance company might actually try to tell you that they will only authorize a certain type of care, only cognitive behavioral therapy, or only something because it's considered evidence-based, which means it has research behind it that shows it's effective. Medically negligent, basically the opposite of, well, it's not the opposite of medical necessity. So medically negligent is the violation of the accepted standard of care by act or omission. So notice that that definitely says omission. So this will come into play when we get down to talking about your therapist letter and your doctor letter, because if the company denies something that is medically necessary, then they can be held liable for medical negligence. Treatment modality, that's what I said earlier, that CBT, DBT, ACT, the specific type of treatment that your therapist or doctor is recommending. Note that modality also includes medication, so if you have been diagnosed with depression or anxiety and you need medication for that, that's part of your treatment modality. Non-quantitative treatment limits, also known as NQTL. This comes into play a lot in your behavioral health benefits because they are non-numerical limitations. With an eating disorder, this is mostly used to try to restrict what level of care you can have, medical management standards, the determination of payment amounts that a provider receives, and all the laws that have been put into place over the last 5 years say that these types of limits in your policy cannot be different for behavioral disorders versus medical or surgical illnesses. So this will come up a lot. Let's see, so key terms related to the insurance. You have single case agreement. This can be really, really handy. It's an agreement between a provider or a facility and your insurance company where that provider or facility may be out of network for you, but because they have a specialized service that you need, the insurance company will make a contract with that provider or facility called a single case agreement. It's for one person for one specific set of treatments, but we've had a lot of luck using this to get coverage at facilities that are out of network. Some policies will state outright what their single case agreement procedures are, and some you have to negotiate. And usually a provider or a facility will help you negotiate that. Peer-to-peer review. This is when your clinician has a conversation with a clinician at the insurance company. The two cases where we typically see this is either if you're already undergoing treatment, either in a program or with a provider, and your insurance company needs to authorize additional care or they're trying to cut off your care. The other place where this will happen is if you submit an authorization request and it's denied, you can ask for a peer-to-peer review before you go through the formal appeals process. Especially important to note is that you have the right, if you end up in a peer-to-peer review, you have the right to request the insurance company's clinician be a qualified provider, i.e. somebody who has eating disorder knowledge or experience. We actually had a case where somebody did a peer-to-peer. A lot of times you get a general practitioner, and that might be okay. But we actually had one where when we dug into the qualifications of the insurance company's clinician, he was a dermatologist. I'm clearly not qualified to be making these decisions. There are four types of claims. Pre-authorization, that's the one we're primarily going to talk to today when you get a treatment plan, whether it's outpatient, residential, and you're asking your insurance company to authorize this treatment plan. An urgent care claim is when you have to have a decision. Generally within 72 hours, your policy will tell you exactly what that time is. This happens to us. I work personally with a lot of type 1 diabetics who have eating disorders. So we run into this a lot when the person is in the hospital in diabetic ketoacidosis, and we don't want them to go home. We want them to go straight from the hospital into a treatment facility. This can also happen if you end up in the hospital with some sort of cardiac complication, severe underweight, that kind of thing. A concurrent care claim is when you are in treatment and you want to request an extension addition to your treatment plan. And then a post-service claim is what most of us are used to. That's just when you go to the doctor, you have the service, and then the claim is filed. A utilization review is something that the insurance companies have come up with where they will go back and review the patient's file and review all the claims, no matter what kind, that have come through with them. They use this to minimize costs. They say that it's in your best interest because they are determining if the recommended treatment is appropriate for you. But this is also where they can really trip you up because they can come back and say, well, we don't think your treatment team is using the right therapy, and so we're not going to authorize, we're going to cut off your authorization for your treatment plan, and we're telling you that you are done, or you have to do something else, you have to go to a lower level of care, something like that. Before I move on, are there any questions about those key terms? I'm not sure if people raise their hands or how this works.
Yeah, no, I'm taking a look at our list of it.
Okay.
So nothing so far. Still making comments.
Okay.
Yeah.
All right. Okay, levels of care, which I've referred to a couple times. I'll go through these quickly because most of the people on this call probably already know this, but there's inpatient or hospitalization, where you're staying overnight, you're medically or physically at risk, you're having intensive 24-hour, 7-day-a-week therapy. Residential is very similar, overnight. Usually to be in residential you have to be already medically stable, but you still require a daily assessment and you need 24-hour supportive environment. The biggest difference between inpatient and residential is really the facility's license. Sometimes the building and the staff can look very the same, and it's just whether or not it has that hospital certification. And obviously if you're medically unstable, you will be in an inpatient facility. Partial hospitalization program, also known as PHP. You don't stay overnight, you're medically stable. They usually run 5 to 7 days a week, 6 to 10 hours a day. You'll get 2 to 3 of your meals per day in the program. Intensive outpatient or IOP. Very similar to PHP, it's just less intense, fewer days a week, fewer hours a day. And then outpatient therapy can be either a single provider or a treatment team. You may have 1 to several appointments per week, primarily outpatient. So when your insurance company is referring to levels of care, this is what they're talking about, and very often they will want to authorize the lowest level of care possible, wait for you to fail at that level of care before they will move you up. So we'll talk about in the therapist letter and the doctor's letter how you make that case that it will be medically detrimental to the patient to go through that failure process, and to just, you need to start at the correct level of care. Let's see, types of insurance policies. There we go. So this is important to know because it tells you what laws you can leverage and who you might be able to go to if you're having trouble with the insurance company. The fully insured group health plan, that's what most people have through their employers. It's insured and administered by a third party. You'll be familiar with the insurance company name, for example, Blue Cross Blue Shield or Group Health. The plan administrator could be anybody, Benefit Management Inc. Often who that plan administrator is hidden to you. You just call the number on the back of your insurance card and the administrator picks up. Then there's a self-funded group health plan, very similar, provided by your employer. The difference is that it's not insured by a third party, it's funded by your company. So that plays a little bit into what laws are applicable. But it does mean if you find out that you have a self-funded health plan, you can, if you're having difficulties with the insurance company, you can go to your human resource department, explain your situation to them, and they can step in and be an advocate for you. An individual health policy, that's one you purchase on the open market or through the new state insurance exchanges. A government plan, unfortunately, a lot of the laws don't apply to government plans. They've exempted themselves. So this could be because you're a government employee, you work for a city, a state, the federal government. Medicaid and Medicare are both government plans. TRICARE, which is part of the Department of Defense, is a government plan. State pools, a lot of states have pools where you can get reduced cost or free health care insurance. That's also considered a government plan. There is a new trend. The one thing I want to make sure, especially with the group health plans, there's this new trend where the administrator of the medical benefits will be a different company than the administrator of the behavioral health benefits. And that can cause a lot of difficulties and challenges when you're trying to get authorization for certain types of treatments, and one covers the labs, and one covers the therapist, and one covers the doctor or the nutritionist, and the other one covers the psychologist. You have the right to have one case manager. Whether that case manager sits on the medical side or the behavioral side, it doesn't matter. But you have the right to request one case manager and make them do all the coordination and syncing of your benefits so that you're not at home trying to do that. All right, so the laws, there we go, and guidelines I was talking about. ERISA is the big one. It applies to all group health plans. And this is a great quote. ERISA imposes higher than marketplace quality standards on the insurance companies and requires that decisions be made solely in the interests of the participants and beneficiaries of the policy. Which means if you have a group health insurance plan, they have to authorize for you the best possible care. It's against the law for them to authorize substandard care. So if your therapist submits a treatment plan and they come back and they say, well, we want you to go to this lower level of care, we want you to go to this general behavioral facility instead of an eating disorder specific facility, you can come back at them with this, that they have to comply with ERISA, which is a higher than marketplace quality standard, and that their decisions have to be solely in the interest of the participant. The Mental Health Parity and Addiction Act, also really, really big. This one applies to both group and individual health insurance plans. We'll get into a lot of the specifics on another slide. The Health Insurance and Portability Act, that was sort of the beginning of the good news. That one governs your privacy and the portability of your insurance. That was the beginning of, you can't be denied coverage for a pre-existing condition. The Patient Protection and Affordable Care Act, also known as Obamacare. How it applies varies a lot based on the individual plans, but there are some general parity that it brings into place, and we'll go through that on another slide. This particular law case, I throw this in there because if I have an insurance company who is being difficult, and this probably comes more into play when you're going through an appeal than your initial ask. But this is a Supreme Court case. It was decided in favor of the patient against the insurance company. And in the decision, this is a quote from their decision that says, the only relevant question is what is in the best interest of the patient. And that's great to throw that legal precedent back at the insurance company when you're going through an appeal. The APA practice guidelines, there's a ton of legal precedent that says an insurance company must follow those APA guidelines. A lot of insurance companies try to set their own criteria and their own guidelines for eating disorder treatment. They're not actually allowed to do that, but they will try it. And so referencing these APA guidelines, and we'll get into that a little bit later, is important in your initial ask. And then the Diagnostic and Statistic Manual, DSM-5 is the current one. Insurance companies are still trying to catch up, but it's out there. It's been out there since last year. It's been out there for a year. And so they have to use those criteria. And it's important for things like the old definition for anorexia required that a person be at 85% or below ideal weight. That definition has changed, and now it says simply a significantly low body weight in the context of age, sex, development, and physical health. So your insurance company can no longer come back to you and say, your patient weighs too much, to be diagnosed with anorexia. That's not, they can't do that anymore. See, okay. So the Patient Protection and Affordable Health Care Act. There's a lot of great stuff in it. It has a definition for essential health benefits. As of January this year, every single policy sold in the United States, whether it's a group health plan, an individual plan, a government plan, every single policy has to include the essential health benefits. It outlines exactly what those are, and included in that outline are mental health and chronic illness. It allows children to remain on parents' policies until age 26, which can be wonderful when you have a young adult who's trying to get coverage. Their company might not provide coverage, or they might not have a policy at all, and they don't have to have been on your policy all along. You can put them on your policy when they're 22 or 23 so that they can access these benefits until they're 26. Insurance companies can no longer deny coverage for pre-existing conditions. Did I go the wrong way? They cannot have exclusions for specific conditions. I think I have an example of that when we start actually going through our policy later on. This one is important. The insurance policies cannot discriminate based on geography, facility type, or provider specialty. And that is for both benefits and for provider fees. So they can't, offer your therapist a different level of, fee than your doctor just because they treat behavioral instead of medical conditions. It also means that they, if you need to go to a facility in California and you live in Utah, they can't discriminate based on that. They can't discriminate based on the facility type. We'll talk about that, especially applies to residential centers. The insurance company is required to provide specific criteria used for their medical necessity determination. So this has been really useful by asking. You'll see later that I will have you ask your insurance company for that medical necessity criteria, because then you can make sure that when you submit your ask, it meets their criteria. Used to be you'd get a denial letter. The denial letter would say, is not medically necessary, but that would be this big black hole. You didn't really know how they came to that conclusion, and now they have to tell you. It also disallows differences in what I had talked about earlier, that NQTL, and requires parity for intermediate levels of care. Again, that particularly comes into play with residential. And then it eliminates lifetime maximums. So if you have a patient, or if you or your loved one has been struggling with this eating disorder for 10 years, and they've already been in 3 or 4 different facilities, your insurance company can't say you've maxed out your benefits, that they can't do that anymore. All right, mental health parity. So this is that Mental Health and Addiction Equity Act. So what does parity mean exactly? It doesn't require parity itself doesn't require mental health coverage. The Affordable Health Care Act now says all policies have to have mental health coverage. And then whatever mental health coverage is in there, it must be equal to medical. And that applies to all the financial stuff like deductibles, co-pays, out-of-pocket limitations. It applies to treatment limitations, the number and frequency of visits, days of coverage. If they let you go see your medical doctor an unlimited number of times, they have to let you go see your psychologist an unlimited number of times. Out-of-network benefits have to be the same for both. Emergency care has to be the same for both. Prescription coverage has to be the same for both, and that especially applies to how they determine what is a quote-unquote formulary drug, because that affects how much your copay is. There is a small employer exemption on parity. It varies from anywhere from companies less than 25 employees to companies less than 100 employees, depending on what state you are in. There are certain federal parities that everybody has to follow. They're not completely specific, and states have their own mental health parity laws that they have passed that get down into more details, such as how do you define a severe mental health condition? Or what is the minimum level of mental health coverage? The federal law says you have to have some mental health coverage. Then each state has further defined what the minimum amount is. And so in this case, state prevails over federal on the specifics. That can have an effect if you happen to work for a company that has offices in multiple different states. We had a client working in Washington State. The branch of the company that she worked for was in Washington State, but the corporate office was in Texas. The insurance company was Blue Cross Blue Shield of Texas, and so that meant that the Texas state parity laws applied, not Washington, and in her case, Texas, as you can imagine, has doesn't have as much parity, doesn't have as much in favor of the patient as Washington State. And so she wasn't able to leverage a lot that Washington State parity. Let's see. Another example, if a plan or issuer classifies care in a skilled nursing facility or rehabilitation hospital, then the plan or insurer must likewise treat any covered care in a residential treatment facility or mental health. That is actually directly out of the final mental health parity rules that were published last November and went into effect January of this year. And that's probably one of the biggest things for people with eating disorders, because what this says is your plan, I've never seen a plan that did not cover skilled nursing facilities. They call it intermediate care. And if your policy covers intermediate care for anything, it has to cover it for mental health disorders, which means your policy has to cover treatment at a residential treatment facility. That's big, and that's really been key since last November. And then another example would be if the plan treats home health care as an outpatient benefit, then any intensive outpatient program like a PHP or IOP also must be considered an outpatient benefit, and so your out-of-pocket for that program would have to be at the same outpatient copay as for the home health care. Let's see. I could probably go on and on about mental health parity, but I want to make sure we get through all of this. If you want more information, I have that on the next slide actually. NAMI, which is the National Alliance on Mental Illness, their website is great. They have a lot of information on mental health parity and mental health benefits. Again, it doesn't apply to government policies, and then federal or Medicare, and then if you want to see if your state has been exempted, you can go to this website, and if you're a state employee or a city employee, you can go and see if your government employer has applied for exemption. And then here's some other websites that where you can find information on mental health parity. That last one, the state mental health parity, is probably, if you only write one of these down, I would write that one down, because that will be important in you figuring out what your insurance company is required to provide in your state. All right, so that should be all the basics. You're probably already feeling a little overwhelmed. So now we're going to go through the pre-authorization steps, which is a lot of document reading and document writing. So I included this cartoon, which I thought was funny. It's a prescription to build up your stamina so you'll be able to fill out all these medical insurance forms. So the pre-authorization checklist. All right, there we go. All right, document every call with the insurance company. This is really important for obvious reasons, but you also, I actually have a whole slide on that, so I'll go over that later. Make sure you get an assessment and a diagnosis and a treatment plan from your provider, and then ensure that the treatment plan follows those APA, that American Psychological Association standards of care. Obtain documents from your insurance company. We'll go through that. Make sure you read your full insurance policy. That's the full 78-page, 90-page behemoth, not the 15-page booklet that you often get from your HR department. You might want to interview a list of network providers, especially if you have a specific person or facility in mind that you want to get authorization for, and if that person or facility is out of network. You can ask the insurance company to provide you with a list of providers that are in network that they would recommend. Then you call those facilities or providers and interview them to determine their level of qualification. It could be you'll find out that there's someone who is equally qualified who can treat you. Most likely you've already done a lot of this research and you will have information to give back to the insurance company that says, you know, my patient needs to go see Dr. Robbins because no one else on your list has the level of expertise that my patient needs. Obtain additional supporting documentation. We'll talk about what that is, and then draft your letter to request authorization. And then once you're done, you just submit it all to the insurance company. So Diana, I don't know if it's just my screen or they seem to be getting a really delayed reaction.
Yeah, we've been getting a couple of questions in, so
okay.
That may be causing the lag. So the one question, and I think this probably results because of so much information, is if attendees will be able to access the slides. And so that came from a couple of attendees. So we are going to post this recording on the NIDA website. And John, if you have no qualms with it, we're more than happy to post a PDF version of PowerPoint to be downloadable as well, that you could follow along.
I have absolutely no problem with it. I think that's a great idea. Some of this information is on our Diabulimia Helpline website, but I know it is a lot of information to try to take in an hour and a half, and especially like the checklist and things, I'm sure it would be nice to have sitting on your desk to go through. Yeah, I have no problem with it.
Awesome, great. Yeah, so we'll make the PowerPoint itself available in addition to the webinar recording, so you can follow along if you want to rewatch the webinar and if you ever want to just go back to the. So that's great. Thanks a lot, Dawn.
Yeah. Okay, good. All right, so documenting every phone call. This is important because, well, let's go through it. Sorry guys, that was wrong. Okay, so first of all, when you call, and you know, what I'm going to walk you through is a very extensive pre-authorization process, probably more appropriate for asking for a residential facility or a long-term PHP program. If you're just trying to get authorization for 3 outpatient appointments a week for the next 6 months or something, you might try getting authorization through a phone call. It's a little bit dangerous because they will always tell you what you get on the phone they aren't held liable for, so having that answer in writing is your best bet. But when you are on the phone, whatever it is that you're asking for, whether it's you're requesting information, you're requesting coverage, don't back down. Ask for a supervisor. I can't tell you how many times I've had to talk to a supervisor, especially about medications. Well, make sure you document the date and time of the call and the duration of the call, because that goes to the insurance company's due diligence. So if you have, you know, a documentation and you show you've called the company 10 times and each call is less than 3 minutes, they're not providing very much due diligence to your case. And that will go against them in any sort of review or appeal. Make sure you mark down the name of the person you talked to, how many times you were transferred. Not so much if you're asking for a supervisor, but sometimes you start to get that runaround. Well, I can't help you, let me transfer you to so-and-so. Well, I can't help you, let me transfer you to so-and-so. That kind of also goes to due diligence, that sort of pass the buck. Obviously, the content of the call. Make sure at the end of the call, you verify what the next step is, who is responsible for it, whether it's them or you, and if it's them, by when it will happen. If it's you, by when is it due, and then put that date on your calendar and follow up if you haven't heard back from them. And then after you've done, every time you talk to them on the phone, send a copy of what you have documented, the date, the time, the duration, the person, the content, all that. Send it to the insurance company or the administrator and request that it be put into the patient's file. The reason you do this is that if your case goes to a third-party review, which is a first step you can take if you get denied before you have to go through the whole appeals process. If it ends up in front of a judge, even on, peer-to-peer review, whatever, the only thing that third-party reviewer or that judge is given is the patient's file. So if you don't send in your documentation, the only thing that person sees is what the insurance company wants them to see. Lisa Cantor, who does a lot of this litigation, has seen files where the insurance company's documentation of a phone call is completely contradictory to what the patient said. And so it's important to have your side of the story in that file. Okay, the assessment and diagnosis. Make sure you get a complete diagnosis. So that's any and all medical and mental health conditions. There might be an eating disorder, there might be co-occurring mental health disorders, depression, anxiety, bipolar. There may be medical conditions, type 1 diabetes, gastroparesis, osteoporosis, cardiomyopathy, anything that is wrong with the person, truthfully, whether or not it's related to the eating disorder, make sure there's a complete diagnosis. And partially because those co-occurring conditions can actually come into play in determining your benefits and can help you get a little bit more leverage out of your policy. Make sure somebody has done a formal assessment and determines the level of care needed for the patient at this particular point in time. Doesn't matter what other levels of care they've had in the past. This is your request for where they're at right now. Find out who your policy allows to determine a diagnosis and treatment plan. Some policies will only allow a psychologist and not a medical doctor. Some policies will allow anybody, but you want to make sure that you're in compliance with your policy. And then, of course, that person should provide a treatment plan, and that treatment plan should be as complete as possible. The frequency, duration, intensity, so whether it's, even if they're recommending a step-down process, so 6 weeks in a residential, 2 months in partial hospitalization, followed by 6 months of outpatient, whatever that treatment plan is, try to make it as complete as possible. Especially if there's extenuating circumstances or co-occurring conditions, the treatment plan should specify the provider experience and credentials. This is especially important, and at the very minimum it should say that the treatment provider must have experience and expertise in eating disorder treatment so that your insurance company doesn't try to shove you off to just a general behavioral health provider. And then if you're asking for entry into a facility, what those facility requirements are. Inpatient, residential. I work with a lot of type 1 diabetics with eating disorders. Well, I work exclusively with type 1 diabetics with eating disorders. And so in our letters and in our treatment plans, the facility has to have a program specifically for that comorbidity of diabetes and eating disorder. So anything like that would also go into the treatment plan. Let's see, what is the APA standard of care? So this goes to determining a patient's initial level of care or change to a different level of care. I'm just going to read this because it's really important. In determining a patient's initial level of care or whether a change to a different level of care is appropriate, it is important to consider the patient's overall physical condition, psychology, behaviors, and social circumstances rather than simply rely on one or more physical parameters such as weight. This is a direct quote out of the APA guidelines. And notice when I pull up those guidelines, there's 10 of them. We used to have a worksheet that would help a provider work through this. It was all based on the DSM-4 and hasn't been updated yet, so we took that off our website. But your provider should at least try to go through and document all 10 of these for the patient, or at least most of the ones that apply. So it's not just medical status and weight. Notice those are only 2 of the 10 that determine what level of care. So when your insurance company tries to say they're medically stable and not skinny enough, that doesn't cut it. There's motivation to recover, co-occurring disorders, structure needed, that's always a big one. You know, if you have a patient who won't eat without a certain level of structure, then they need to be at a certain level of care. The ability to control compulsive exercise, purging behaviors, if a person needs to be watched every time they eat, that requires a certain level of care. Environmental issues that can be in the home, in the community, whatever those environmental issues are. And then the geographic availability of treatment. So the documents to obtain, there we go, from your insurance company. First, your full insurance policy, so that's what I was, your human resource department won't likely have this. You'll have, if you call the number on the back of your card and just ask for the full insurance policy, sometimes they'll be able to email you an electronic copy. I find those are easier to work with, but sometimes all you can get is the hard copy 90-page manual in the mail. Ask them for their medical necessity criteria for both mental health and medical disorders. And obviously, if they have anything specific, any guidelines, treatment guidelines, specifically for eating disorders, you'll want to get a copy of those. And then we already talked about getting that list of in-network facilities or providers. If you are going to a facility after admission, you can ask for this at the same time, but once you've gone to a facility, you want to make sure that you ask for those peer-to-peer review guidelines in case you get caught up in one of those. One note on those peer-to-peer reviews, again, this is more related to after you have started treatment and you're in a treatment process, not prior to. We have seen, especially for people who are in residential and inpatient, insurance companies will get really ridiculous, and they'll start asking for peer-to-peer reviews every 3 days or every 5 days. They want to reevaluate the patient's condition, even if on admission they were assessed at needing a minimum of 4 weeks. If the company is getting completely ridiculous, you know, call them on it. You know, the analogy that I really like is, you know, how often do they ask for peer-to-peer reviews in cancer treatment? Because remember, we now have mental health parity, and they can't treat an eating disorder different from, they can't treat a brain disorder different from any other medical disorder. And I'm pretty sure that someone who is undergoing chemotherapy they don't require a call with that person's doctor every 3 or 5 days. And so call them on it if they're getting really ridiculous. Okay, reviewing your policy. So read the entire policy, yes, all 78 pages. Have a good cup of coffee with you. Things that you're looking for, the type of policy, so whether it's that third-party insured or self-funded, and whatever their authorization process is, it will probably be laid out for you. You're going to go through definitions, exactly what the medical benefits are, exactly what the mental health benefits are, what their definitions of in-network and out-of-network are, and what those benefits are, any diagnosis requirements that may be listed in the policy, and then know what your appeals process is. Hopefully you are going to get a yes on your first try, but it's still good to know what that is in case it doesn't happen. So knowing how to read a policy is not something that we are taught in school. So the next 9 slides are pieces of policies that I've pulled out that we can look at together. So I can kind of help walk you through the highlighted things to look for. And Diana, as we're going through this, if people ask questions, feel free to interrupt me, because this is kind of like way down in the weeds type of information.
Sure thing.
Okay. Okay. So every policy has some sort of grid that looks like this for in-network and out-of-network. Hospital services, that applies to any inpatient facility. And if you're going to a facility that is residential, they may, but you know that your patient is going to need to be in there for a long period of time, you know, a couple months or 3 months. You may have them initially admitted into that inpatient unit to use up as much of this sort of higher level of benefit as you can before they're transferred into the residential unit. Because you can see this policy 100% after deductible, so they have excellent inpatient benefits. The medical therapy services, tube feeding in a hospital setting, no, insurance companies don't usually argue with that. We have had clients that have gone home with tubing, and we've had families that are doing family-based therapy. They're trying to do refeeding at home, and they need tube feeding at home. And so this is where these outpatient services and non-hospital services come into play, and you're allowed to access these benefits for at-home tube feeding. And then we've talked already about how that skilled nursing facility is that intermediate level of care, and if this, you can see right here, both hospital-based and non-hospital-based facility, 80% after deductible. That means that's the coverage for residential. Now you will also see that in this policy, there's a maximum of 100 days. Because they have made the limitation for all conditions, medical and mental health, they can actually do this. So you would only get up to 100 days of residential, which in the United States would be amazing if we could get somebody to stay for 100 days. But again, you might be able to sort of leverage, check them into the inpatient unit, and then transfer them to the residential. Behavioral health coverage. Every policy will have a section specifically for behavioral health. You'll notice that in this policy it goes straight from inpatient to outpatient. This policy doesn't specify residential, but both the Affordable Care Act and the Mental Health Parity Act requires that they have this intermediate facility services. So even though it's not in the policy, and if you call and talk to somebody on the phone, they may tell you, you know, oh, we can't approve it because it's not in your policy. That doesn't matter. The law requires them to cover it, whether or not it's actually laid out in the policy. And then substance abuse services. This annoys me a little bit sometimes. We see policies where the substance abuse benefits are higher than the mental health benefits, and parity applies to substance abuse as well as medical. So if they have, either in that grid like we were just looking at, or down in the narrative detail like what you see here, where they've got inpatient and non-hospital residential rehabilitation therapy, outpatient rehabilitation therapy, and then it goes on to talk about services. they have to apply this level of service to the mental health disorders as well as substance abuse. All right, nutrition. So I won't read the whole thing, but if you read through this detail, you'll see that this policy is trying to say that it will authorize nutritional supplements and nutritional therapy when they're medically necessary based on certain metabolic disorders. It's supposed to be disorders. And that coverage is exempt from copayments and deductibles and coinsurance. So the laws now state that they can't discriminate based on condition. So if they're willing to pay for nutritional therapy and supplements on an outpatient basis for these metabolic and hereditary conditions, then they have to do it for an eating disorder also. And where we have seen this come into play again is with families who are using FBT or Maudsley to try to do refeeding at home. So they don't, cover ice cream for high-calorie shakes, but if you need, 20 bottles of Ensure or something like, or something specific. Our clients, we see a lot of gastroparesis, and that requires some very specific medical or nutrition therapy as they're working through recovery. And then kind of the same thing, this NQTL, those non-quantifiable limits, they can't put those on anymore. Nutritional, and then this paragraph that says nutritional counseling, you'll notice that it does specify your benefit will cover 2 visits per benefit period. If you find a limitation like this in your policy, you need to make sure that having more than 2 visits with a dietitian or nutritionist are outlined in your treatment plan, because you will need pre-authorization to get those multiple visits. You can also, if you're struggling with this particular piece of it, getting multiple dietitian visits, sometimes your provider can leverage different billing codes. So they may see them twice on one billing code and then twice on a different billing code. And then you can also leverage other medical conditions. This is probably the only place where being a type 1 diabetic helps, because almost every policy has unlimited diabetes education, and so we can get unlimited dietitian visits through that benefit. Okay, read through your policy definitions section. You may need a second cup of coffee for this. But this is where you can find a lot of little nuggets of gold to make them authorized. And one of the reasons you're reading this policy isn't just so that you have all of this great knowledge, but you want to incorporate all of this knowledge into your therapist's letter, into your letter where you request authorization for treatment. Because if you know this ahead of time and you can include this language, if you can say things like, per the definition of hospital in our policy, this and this and this, then that's how you get that initial yes. Because 2 things happen. One, they read that and they realize you're serious, you know what you're talking about, and you're going to be a pain, and they might as well just approve you right away. And then secondly, they know they're more likely to lose on appeal. So the first thing look for in everyone is what the definition of hospital is. And in this particular policy, they actually state psychiatric hospital. And because of that, this policy will cover any inpatient facility. And this policy also has unlimited hospital stay, which means the person could stay in an inpatient facility for an indefinite period of time. And it doesn't have to be, UCLA hospital. It can be a psychiatric, Cumberland Hospital for adolescents. They are a behavioral hospital, but they have hospital certification in the state of Virginia. They have an inpatient unit And so a person could go to Cumberland and stay in that unit for an indefinite period of time. So the next one down, we have definition of inpatient. And you'll notice that this definition of inpatient applies to situations where partial hospitalization is recommended by the physician. That means that some PHP programs would qualify. So, for example, UCLA has a complete step-down program. They have inpatient, residential, partial hospitalization, outpatient. Because they're a hospital facility and in their PHP program, the patient would be accessing hospital facilities and hospital services while they are there. They can be, all of that program could be considered inpatient and again have unlimited benefits. And then this last one, you'll notice that this policy actually states, interestingly, services for diagnoses that are listed in the Diagnostic and Statistics Manual of Mental Disorders, that's the DSM-5, that is current as of this date. So you want to enforce the use of DSM-5 anyway, but the person who has this particular policy, they actually have a clause they can point to that says you have to, accept this diagnosis of my person. Let's see a few more definitions. So medically necessary, some policies will have it laid out actually in the policy, some won't. This one did, and you can see that it is in the judgment of the attending physician. Then if you go down to the definition of physician, you'll see that a physician is anybody licensed by the state, including a dentist, a podiatrist, a chiropractor, a psychologist. So that means that you don't have to have a medical doctor submit medical necessity criteria. Your psychologist can submit the medical necessity criteria for your patient. And then reasonable and reasonableness. The two biggest problems, I may have already stated this, but the two biggest problems that we see are insurance companies that have their own guidelines that they require you to follow instead of the APA guidelines, and then violations of parity. It's the other big issue that we see. And you can see in this paragraph, the insurance company is trying to say that reasonable or reasonableness is going to be defined at the plan administrator's discretion. This does not negate the standards of care. So if you get those guidelines from your insurance company and they are subpar, they can't force you to use those if they're contradictory to the APA guidelines. All right, some of the policy covenants that you'll find. This plan, this was really interesting. They specifically say in this plan that all of their mental disorder coverage will comply with federal parity requirements. And because they stated outright in the policy, in this particular case, federal trumps state. So if the federal law provides you better benefits than your state law, then you get to access that federal law. And then case management, a lot of policies have a clause for case where they will provide a case manager for you. This is somebody who will oversee the entire treatment plan. They'll coordinate care with multiple different doctors and therapists. I don't often recommend this, but sometimes if you see this in your policy and you happen to have a patient or you or your loved one is one of those is a very complex case because they have multiple co-occurring mental health disorders, or maybe it's a persistent case where this person has been in and out of treatment for 10 or 12 years. Accessing that case manager benefit, because you can ask for a case manager as well as the plan may elect to give you one. That person can become an advocate and a voice for you inside the insurance company and can just take some of that burden off your shoulders in managing the treatment plan. And then speaking of co-occurring disorders, look for anything in your plan that you might be able to leverage if you do have a patient that has either a co-occurring medical condition or a co-occurring mental health disorder. I already talked about this first one with the diabetes training and education. We are able to often use this to get unlimited CDE or RD services. And then in this second one, the second sentence, if the service you need is not available in the network, the health plan will consider coverage of that service by a non-participating provider. And this, especially if a lot of policies have this stated outright. And if you find this in your policy, it is a great way to leverage getting that provider or that facility that you really want to go to or that you really need to go to. The patient has the right to see a provider who specializes in their co-occurring condition. And it's not uncommon for a person to present with, ED plus depression plus anxiety, or ED plus bipolar, or ED plus substance abuse. And there are programs and facilities and therapists who specialize in that comorbidity. And as the patient has a right to go see that person, whether they are in network or not. In a second, when we talk about the therapist letter, we'll talk about outlining, that goes back to what I had talked about earlier, outlining the credentials for the provider that the treatment plan has. All right, medical necessity. So this is another definition of medical necessity that was in a policy. For some reason it's not. There we go. Shoot. Sorry, guys. I guess I need to be more patient. Okay, medical necessity. So this was a really interesting find for me. These first two bullet points basically state that the insurance company will use standard of care, appropriate standard of care, in their definition of medical necessity. And then in this third bullet point, it says, in conformity at the time of treatment with medical management criteria and guidelines adopted by the insurance company. Well, the insurance company cannot use their own guidelines to contradict the first 2 points up here. And so, as long as you point out that your treatment plan is in accordance with the OSAPA guidelines, they kind of have to go by these first 2, and if they give you a denial based on this third one, you have grounds for an immediate appeal. I mean, their own policy contradicts itself. So this was just a really interesting find. Every policy has a list of exclusions. The biggest one, you'll find a bunch listed under behavioral health services. This first one where it says long-term residential services are not allowed, obviously the law no longer allows that. You may have an old policy that says this, but they can't enforce this anymore. Technically, they can't enforce it for the new plan year after January 2014. So if you have a plan year that started last October, they kind of get this weird grandfather thing where they can keep that limitation until until October of 2014. So there is that kind of weird. That's on the Affordable Care Act. The Mental Health Parity doesn't have that same grandfathering that applies right away. Okay. Treatment for chronic behavioral conditions. Once the individual has been restored to the pre-crisis level. Companies try to use this. Almost every policy has this bullet point in it, and companies try to use it to deny additional care for somebody who has been chronic, and chronic is defined as having the condition for more than a year while still undergoing treatment. And they'll use it to try to deny an increase in level of care. So the important things are that, well, first of all, kind of going back to that cancer analogy, an insurance company wouldn't deny another round of chemo to a cancer patient because the first two didn't work, or because the patient has chronic cancer, or their treatment outcome hasn't been what was originally expected. And under Parity, you can't treat a mental health disorder different than you would a medical condition. Aside from the ethical issues, just from a legal perspective, the insurance company can't do that. Usual and baseline condition, because you see that increased care is medically necessary when a patient is not at a level of control and stability consistent with their usual and baseline condition. So this was defined initially really intended to be used for that schizophrenic patient who goes off their meds and then has to be hospitalized or put into a program until they're back on their meds and restabilized, and then they can go home. It was not meant for somebody who, the treatment isn't working at the rate that the insurance company wants it to be working. Usual and baseline can't be underweight, it can't be purging daily. I mean, just because that condition has been existing for a long time doesn't mean it's usual or baseline. It has to be an acceptable human condition. And then not usual baseline, so i.e. you've got somebody who's maybe kind of been in recovery and they're relapsing. That relapse can be weight loss, it can be increased binges, it can be the addition or resumption of self-harm, it can be a change in labs, but it doesn't have to come with a change in labs. And it can be a change in a co-occurring disorder. Let's see. We've talked a lot about nutritional supplements, because I'm starting to run out of time, so I've got to get going. And then weight reduction programs, you have this kind of might come into play in binge eating disorders. You have to be careful in how a dietitian is used with your binge eating disorder patients. Don't let the insurance company define them as a weight loss benefit. It's still a mental health disorder, and that's a mental health necessity. Okay, so good faith. I love this cartoon. You can see the alternative operation is the caveman with the axe and the hammer as the alternative operation method adequate to my health insurance. So good faith. Insurance companies are contractually obligated to act in good faith. There's a lot of court precedent around this, that the benefit has to be in the best interest of the patient. At its core, an insurance company has the duty of performing its contractual obligations to you in good faith and not trying to take advantage of what the court calls a vulnerability created by the sequential character of contract performance. It's a bunch of legal jargon, but what it basically means is you have paid all your premiums up front, and now, a year, 2 years, 10 years, whatever it is down the road, you want them to authorize a service. Well, they already have all your premium money, and they can't take advantage of that relationship and now deny you that service that you have been paying for all along. And this good faith, bad faith really comes into play when they're trying to steer you to a lower level of care, reduce your treatment plan, send you to an insufficient facility, that kind of thing. All right, so let's talk about the documentation you need to pull together. You need to get the treatment plan, the letter, records and notes from your therapist, medical doctor, the labs, the medical records. A letter is great if you can get one. If there's a psychiatrist involved for meds, That's optional. Dietitian is optional. Any other specialists you're working with are optional, but if they're a key player in your treatment team, then it'd be good to get letters from them. And then from the school or employer. So if you're having to take a leave of absence, if you had to drop out of a semester, failed out of a semester, if you have to go on FMLA, which is Family Medical Leave. Way back at the beginning when I talked about HIPAA, the HIPAA law, one of the things HIPAA put into place was FMLA, Family Medical Leave, which says if you need to leave your job for up to 6 months to treat a medical condition, your company can't fire you. They have to hold your job for you so that you can come back when you're done. I know a lot of people's concerns around going into treatment or taking time off of work is that loss of job, and that HIPAA law, that FMLA, companies are required to have for you. And then, of course, your own letter. Make a clear and specific ask, and then all this other documentation that you've pulled together, mail it in together with your letter rather than piecemeal, because then you kind of have you're making one case for this treatment authorization, and ask that it all be placed in the patient's file again so that your side of the story is in there. So the two biggest pieces are the therapist's letter and the doctor letter, and of course your letter. So in that therapist letter, make sure they depict the history of the patient's disorder, explain what the current assessment and diagnosis is, outline the medical necessity in accordance with the insurance plan. So you may ask for that and then provide it to the therapist or the psychologist. Outline the treatment recommendation, make sure it's in accordance with APA, which we've talked about a lot. List the expected outcome, which obviously is restoring the person or having the person be in recovery. But have them be a little bit more specific than that. So if the person has bulimia, the treatment outcome, might be, reduce episodes of purging to less than 1 a month, something like that. And then also list the expected progression of and dangers of an untreated disorder. If you look at some of the sample letters that NIDA has on their website, they have a paragraph in there that talks about anorexia nervosa has a 15% mortality rate. It's the highest mortality rate of any mental health disorder, and that's what. So that's a possible outcome if the company does not approve this treatment plan. And then the doctor's letter, list all the past medical conditions and complications. Even if they've resolved now, there needs to be a good medical history in there, especially if there's been any emergency room visits or hospital stays. List what their current condition is, including either low weight or recent rapid weight, right? So if they're not at a low weight, but they've lost a lot of weight in the last 8 weeks. Obesity actually now has a diagnostic code, so for your binge eating disorder patients, obesity can be a medical condition, and then of course any abnormal vitals or abnormal labs. List currently medically dangerous behaviors, the likely immediate and long-term consequences of the perpetuation of these conditions. And then the doctor's letter should endorse the treatment prescribed by the mental health professional as medically necessary. And it's great if your doctor includes this sentence at the end of his letter: to authorize a lesser level of care would be medically negligent. That's just sort of putting the insurance company on notice that you're serious. Okay. Is there any questions up to, well, we only have a few minutes, so I'm just going to go through the last 2 slides and then we'll be at questions. Okay, so you've done all of this extensive work, and it sounds like this is going to take weeks, but really it can only take a couple weeks because I know you need to get treatment authorization as soon as possible. And again, you can always call and ask for the authorization verbally, and if you can get it verbally, then just follow up with all this documentation and the request in writing. Because that verbal authorization isn't a guarantee, but it will at least get you in the door. And then if you're going to a residential center, a lot of them have business offices that can help you go through this process. So I love this. So now you send this all in and you're going to get a response, and the response is going to be yes or no. And if you get a no, I love this. Your excuses for not providing me coverage have been denied. Probably wanted to say that a time or two. So if you do get a no on your first try, remember, no is just the first step to yes. The letter they send you has to include the reason for the denial and the process for the appeal. If it doesn't, call and ask for that immediately. Also, call and ask them for a full copy of the patient's file. So that will be all of their notes, all of their stuff, as well as all the stuff you've sent in, every claim that's ever been filed. You have a legal right. There's the law says you have a legal right to your file. The Affordable Health Care Act requires that they provide this to you. Ask for the name and credential of the person or group who made the decision. If you ask them this on the phone, you will get a lot of pushback and you will have to ask for a supervisor, but stick with it and ask for that. Again, you could have a dermatologist deciding on whether this is an appropriate treatment plan, and that's not okay. That is not in good faith. That is not due diligence. And then look at how, when you do get that reason, assuming it's in the letter, look at how the medical necessity criteria was applied. The reason I say call first is I will bet about 50% of the time when we have someone with a denial call and start asking for this information, they get an immediate reversal of the decision. I don't know why, but I think that is because the insurance company becomes afraid. They understand that you're going to fight, and they don't want to. They know they're going to lose, and they don't want to go through that fight. You know, it's kind of like that. It's easier. They give you a no because it's easier to ask for forgiveness than ask for permission. So call first, and then if they don't reverse their decision and they don't give you the information, follow up with a written request for this information. Like I said before, especially if you have a self-funded plan, you can go to your human resource department and ask them to intervene for you. This is key. You have to follow your recommended treatment plan, or else you won't. In order to sue an insurance company, you have to have a financial loss, so you have to follow your recommended treatment plan. If your person is stable enough that you can go through an appeals process first without having to pay out of pocket, you know, you can do that, but sometimes you have to pay. You have to go ahead and follow the recommended treatment plan, pay out of pocket. Some providers and some facilities, if they know you're going through an appeals process, will not require you to pay up front, and they'll just sort of have a bill going for you. And if you do end up having to pay out of pocket, ask your provider or the facility to split the bill into covered and non-covered costs. So if you're in a PHP program and they bill for the therapist, the dietitian, group therapy, they bill for those separately, those will probably get covered under a post-service claim, no problem, and then you'll have to pay out of pocket for meals or you know, room and board if you're a residential kind of, but that kind of maybe will help while you're going through the appeals process. General appeal. Oh, all right, I'm not going to go through this slide because we only have 5 minutes left. Make sure you read the appeals process in your policy so that if you get a no, you know exactly what to do and when your deadlines are and all that kind of stuff. Like I said, you can ask for an external review or a third-party review as a first step before you have to go through the whole appeals process. Cantor and Cantor, they specialize in eating disorder law. If you get to the point where you need to, you're in your third appeal and you're thinking you're going to have to, they will help with really high-level appeals as well as lawsuits. uninsured options. Under the Affordable Health Care Act, there's now a lot of subsidies you can leverage if you buy your plan online, and about half of the states have expanded Medicaid. So if you're in a state that has expanded Medicaid, that's great. Here's a list of different foundations and organizations that offer eating disorder scholarships. Pull all of this off because you're going to have the PDF version. All right. I'm sorry, but stress caused by, here you go. All right, we have like 3 minutes for questions.
Yes. So first of all, excellent information, and you know, as John reiterated that, we will be putting up the PowerPoint as well as the webinar, so we always read this time and time again and follow along using the PowerPoint material. Yeah. So one question that had come in was in regards to their daughter. They said that my insurance company won't cover my daughter's residential treatment any longer, and they want her to exit even though her team says that she needs to stay. What can I do to fight back and keep her at the facility?
So the first thing is you need to get the criteria that they are using to say, because what they're saying is that the treatment plan being recommended by her team is inappropriate. That's essentially what they're saying. And so you need to find out what are the criteria that they are using to make that decision. Get a copy of the criteria that the treatment team is using to make the decision she needs to stay. I guarantee you that treatment team's decision is in line with the APA guidelines, and so then you send them, you call them, because if she's in the treatment facility, you don't have time to do this by letter, you call them and walk through that with a supervisor. I assume the treatment facility has already done a peer-to-peer review. If they haven't, definitely request that. If they have, find out what the qualifications of the insurance clinician is, because again, if it's a GP who has no eating disorder expertise, he's not qualified to be in that peer-to-peer review.
Great, thank you. That's super helpful. We have one more question that I think we can get to from an attendee, and they asked, what can the primary therapist do to ensure that patients are covered in times when the insurance is denying them coverage?
Okay, I'm sorry. Can you repeat that question because you cut out on me?
Oh, sure. What can the primary therapist do to ensure that patients are covered in times when the insurance company is denying their coverage?
I guess I'm not sure what you mean by ensure they are covered. When you make the initial authorization request, make sure that you're asking for however many sessions that therapist thinks it's going to be. Under mental health parity, you are now entitled, I've never seen a policy that limits the number of times you can go to a medical doctor, which means they can no longer limit the number of times you can see a psychologist or a therapist. So probably the first thing I would do would just be call and say, under the Mental Health Parity and Addiction Equity Act, effective January 13th, 2014, you cannot have different limitations on outpatient visits, and challenge them. And you might have to do that in writing too. I have found therapists will generally work with you, and if they know you're going through a difficult time with your insurance company, they'll just let the visits kind of rack up. Make sure that the therapist continues to submit them. That's important. Even if you have been denied or you have some sort of period, where you've been denied, make sure the therapist is continuing to submit those claims, because you need those denied claims to form an appeal.
Great tip, Dawn.
Okay.
I think, and I just want to get to a couple of resources to share with people, but we can certainly collect more of your questions for Dawn and send them over to her. She's been super helpful and says that she'll be able to help us out with those questions and get them back to you. So, so let me go ahead and I just want to share a couple of resources for all our attendees and listeners. If you'd like to learn more about eating disorders and get involved with NEDA and other initiatives, please feel free to visit us at our website, nationaleating.org. Our PFN webinar series is located under the media tab of the NEDA website, and that is where this webinar will be located. You can also get involved in NEDA awareness. Our NEDA awareness website is still live, and you're more than welcome to check that out until 2015. Available. Our annual NEDA conference, Thinking Big, Uniting Families and Professionals in the Fight Against Eating Disorders, will be happening in October 16th to 18th, and that'll be held in San Antonio, Texas. So if you're around that area, if you're interested in attending, please and find out more information about the conference by visiting our website. And Gert's Books is a great resource for finding out more information and books about eating disorders and many other issues that are related. Of course, if you need help or if you know someone who is in need of help, please feel free to give our helpline a call. They are available Monday through Friday, and our volunteers are wonderful resources who are able to help find referrals for you, as well as additional insurance scholarship information as gone slightly on before. Our NEDA Navigator program is a wonderful program where you can talk with others who have been through the road to recovery and the process of insurance coverage. They can share their stories and how they were able to do it. And of course, our NEDA toolkits are wonderful resources as well. They really are great comprehensive guides on how treatment, support a loved one, etc. So I encourage you to check those out if you hadn't already. So
can I just add that NEDA has an entire section on insurance, which is fabulous, with sample letters and all kinds of stuff.
Yes, thank you, Dawn, for that. That's a great reminder. Yeah, I encourage you to check out the insurance page if you hadn't already. We have a lot of stock responses and argument points that you can use, and we've heard that they have been quite helpful for some who are trying to extend coverage for themselves or loved ones or secure coverage. So I encourage you to check that out, and if you have any questions, please feel free to give us a call. All right, so I think that we've hit the end of the presentation. So a huge thank you to Dawn for this engaging and informative webinar and for taking the time to share your knowledge and experience. And of course, to all of you who are joining us, you will receive a short question by email about this webinar, and we appreciate your time. Just fill that out and to offer your feedback. If you have any ideas for future webinars, please feel free to let us know. We're always interested in your thoughts and suggestions. You can let us know through the survey that you'll receive after this webinar, or you can email me directly, Diana Calagrides, at nationaleatingdisorders.org. Thank you all so much for joining us. Thank you again. This was wonderful. Certainly helps, a lot of helpful information.
My pleasure.
Okay. Wonderful. So have a great rest of the day, everyone, and take care.
Thanks. Bye.